So I'm a board-certified allergist, as you heard. So I deal with the consequences of climate change and with the patients who are suffering from asthma and allergies. I will discuss the increase of heat effect on the pollen counts, the pollen season, increased rainfall, increased mold spores inside the homes and outdoors. And I'll give you a couple patients' cases of my severe patients and what we have to do to get them controlled with their asthma and their allergies. This is a pollen map. There's 5 regions in the country. And 2012 was a very high pollen season compared to average. And also occurred in 2013 also. Realized during those times we had the Hurricane Sandy, we had El Nino, so there was increased rainfall. So as you have heard about the increased carbon emissions, that leads to the increased pollen count. And a research study from 1990 to 2000 observed that the pollen plant count increased from 5 to 10 grams, with the increase of the carbon emissions from 280 to 37 parts per million. With the CO2 emissions, that increases the growth of the plants. So now the pollens are more potent. Also, we realize in the urban communities in our cities, the pollen season is getting longer by up to 4 days. This is a study regarding the pollen with ragweed. And what they have noticed that in the climates up north, the pollen season is longer. So from 1995 to 2009 in Minnesota, the pollen ragweed season increased by 16 days. And in Canada, it increased by 27 days, and then only 1 day in Oklahoma. With the increased pollen season, the increased pollen count, and the pollen potency, patients are suffering more. So they're having increased allergy, rhinitis, conjunctivitis, and also allergic asthma. So for patients who have asthma, not everyone suffers from allergies who have asthma. But we do know of all the asthma patients in our pediatric populations, almost 3/4 of them is because of allergies. And for adults, it's almost half. So during the pollen season, they have a decline in their lung function. And also we have noticed in our adult population, they're having adult onset asthma later on in life. And for our toddlers, they're having more severe allergy diseases. This is one of my patients. She was transferred to our clinic when she was coming to college here in DC. She's a 24-year-old white female with severe grass pollen. One of my colleagues in upstate New York treated her with allergy injections. Unfortunately, because she was so severe, she developed anaphylaxis in the office and was stabilized. So she transferred into my clinic, and the plan was to start her on a drug called Xolair, which will help to decrease the total level of the antibody, the IgE, before we place her on the allergy injections. However, she decided one day in May of last year to go and cut grass. Even though she has a grass pollen allergy, she's trying to save some bucks. She's a college student. So while outside cutting the grass, she started having hives, asthma, shortness of breath, throat closing sensation. And she was at home taking Benadryl, several tablets, no improvement, went to the ER and realized her vision was blurred. They transferred her to Johns Hopkins Eye Clinic, and on evaluation of her optic nerve, it was inflamed. And it was because of the anaphylaxis. So when she came back to my clinic, I got her stabilized, and we started her on the Xolair drug, which helps bind the anti-IgE. And so I'll discuss more about that later. But the plan for her is to stay on the drug for probably 6 months. It's a very costly drug. It costs like $10,000 a year. And then after that, we get her stabilized, we'll start the allergy injection, very low dosage, and probably in the off-pollen season, and then get her up to maintenance on the shots. It may take maybe 4 to 6 months, for some people even a year. And then we'll pull off the Xolair, and we hope that she won't have any anaphylaxis. Other effects of climate change, which you have heard from the previous speakers, with the ozone layer, it becomes like a little addition on top of the pollen count, a big addition. So with the pollen counts from the emissions from the CO2 are increasing. Now with the ozone layers increasing inflammation. So in the summertime, between the months, especially here in Washington, D.C., from April to June and July is the most busiest time. You have patients who never have asthma who's coming complaining about having bronchitis and coughing symptoms. Now I'm going to discuss the increased rainfall effects. Increased rainfall increase the level of mold spores and dust mites. Because we know in the homes, if you keep the level of dampness low, less than 50%, there are less chance of growing dust mites and mold. With the increased rainfall of the buildings, you're going to have more damage to the roofs and their basements, so they're going to have holes that help in crevices for cockroaches and mites and rats, and those are also allergies, very potent allergies, especially cockroach. Along with the stress of the rainfall and indoor mold, I see several patients who work in public sector buildings, federal government, school teachers, post office workers, and they actually bring in pictures showing the mold in their building, or they're showing me the roof that's leaking in their office with the bucket of water. And so they are stressed out because they can't get the HR department to move quicker, to have them come repair the mold and the leak, and to clean up the area. So having mold in your home, also at work, is a very big stressor for patients. During the recession, back in 2007, 2009, a lot of the patients, and not a lot, but a few of our patients, they foreclosed on their homes. So they were living in their parents' basements or their siblings' basements, and so the whole family was being exposed to damp environments. So they had increased dust mites, increased mold, increased allergies, increased asthma. This is a study that took a survey of several studies, and on the top you see the A was indoor dampness. And it's showing a positive correlation with allergies and rhinitis and conjunctivitis. On the bottom is B, is showing the visible mold, and it still shows a positive correlation of 1.7 with allergies. And what I do, I tell my patients, if you already have pollen allergies and perennial allergies from your cats and your dogs and your dust mites, when you get exposed to mold, it sort of heightens up those other allergies because you already have chronic inflammation. But with mold, it's various times throughout the year. And it comes and goes. Like in this DC area, one day it may be high mold count, the next week is low. So it varies throughout the whole year. This is a study evaluating the homes. They took the dust, which has also the mold alternaria, and they show a correlation between the asthma and the mold concentration. The bedroom, the kitchen, the living, and the house. And it's a positive correlation. This is a dust mite when it's under a microscope, and this is prevalent inside everyone's home. It's inside this building, inside this room. It's everywhere. Everywhere there's carpet, bedding, stuffed animals, it's there. It feeds on our skin. So as we're sleeping at night, the skin falls off. The dust mite eats it. It has passed a bowel movement. That bowel movement goes airborne, the fecal matter, and then we inhale it, and that causes our allergies, the rhinitis. So they grow best when you keep the level of humidity they grow best when it's above 50, so it's better to keep it less than 50%. Now we're going to talk about the cost of the healthcare with the increased global climate change and allergies. Allergy disease affects many people here in America. It's the 5th leading chronic disease. It's $15 billion every year. I see patients probably 3 times during those pollen seasons. They come in the first week of spring, they come the next month for the grass, the next month for the weeds. So it takes time off from work, and also their increased co-pays and insurance costs. Medication costs, overuse. Due to the great pharmaceutical companies we have in our country, patients are self-treating. But a lot of them, they've sort of abused the system, and now they're taking overdose and overuse of the Benadryls and the antihistamines, and to the point where now those medications are not working. So we then resort to allergy injections, and there's costs involved with the injections, also with the coverage from the patients. Xolair, as I mentioned, is a $10,000 a year drug. It's covered by the insurance, but we cannot put every severe allergy patient on Xolair. This is one of my patients. He takes 8 tablets of Benadryl during the spring and summer season. Zyrtec doesn't work, Allegra, Claritin, and Singular, or it doesn't even touch the symptoms. He's on Advair. So we started on allergy injections in the first 2 or 3 years. We're able to taper down his Benadryl to 1 tablet as needed. And he's off his Advair. So skin prick testing, we put drops on, we observe for 15, 20 minutes, and see what come up positive with a hive. So for your patients, we do skin prick testing, or they can do laboratory testing. As allergists, we prefer skin testing if we can. There's some patients who are very allergic, we can't skin test them or do the full panel. So environmental controls I'll discuss about in the home, and also outdoor exposures and medications. For pollens, as you can think, you try to stay indoors during the peak pollen times. There's apps that shows you if it's high or low and what you should do. Home evaluations. There are some physicians who specialize in environmental health. They sometimes do home evaluations. They come and assess the dampness. And there's companies. They'll come and assess the dampness, do an ambient sample of the air inside, and also a sample outdoors. And they compare the mold count and also the species of mold. And they determine which species is normal to have inside your home and which ones are atypical. And also the count. Air purifier, repairs of the building is required, and also for mice. It's important to have a company that specializes in mice removal. So there's several opportunities here for public health to get involved with your congressman about improving the homes and patients who are vulnerable and cannot afford these costly repairs. Dust mite exposure in the home. First line is dust mite covers, bedding, removing stuffed animals. Second line is remove carpets, upholstery furniture, vacuum cleaners, and air purifiers are unlikely to help. Air purifiers will work for the pollens, pets, and the mold, but not for the dust mites. Pet allergies, obviously, don't have pets if you're known to have come from a family who have allergies. It's very hard for my patients to understand that concept. Also keep the bedroom closed during that time, air purifiers, and bathing, preferably once a week, but I understand it's hard for most patients. I tell them at least twice a month. In the office, we do evaluation to rule asthma, and this is a demonstration of the allergy injection called subcutaneous allergen immunotherapy, so it doesn't hurt as much as a flu shot, which is intramuscular. There's been a definite benefits. I'm able to get patients off of their high-dose asthma inhalers. We try to prevent asthma with the allergy injections and prevent chronic sinus disease and bronchitis. With the allergy injections, there is risk. You do have sometimes a hive or irritation at the injection site, and there's a low risk of anaphylaxis. So it's really important to have it performed in a primary care doctor's office or preferably a board-certified allergist's office. SLIT is sublingual immunotherapy. The tablets are been approved by the FDA 2 years ago for grass and ragweed. But most patients in this area that I treat, they have multiple allergies, dust mite, mold, cat, dog, you name it. So the FDA has approved the grass and the ragweed. This is Xolair, as I discussed about. There is preferred for severe asthma patients because the cost of the drug. And this is showing a study showing the decline in asthma exacerbations with Xolair. Poor quality of life occurs with asthma and allergic rhinitis, such as learning and sleeping disorders, mouth breathing, and decreased quality of life. And this is the last patient case. This is a common theme in our DC patients. I've lived in this area all my life. In the past 5 years, my allergies have gotten worse, and I don't have asthma. Fortunately, we do evaluations, spirometry, PFT. They show asthma and skin testing. We start on the allergy injections. But unfortunately, this patient, she's older and she's healthy, so we have no issues of starting them on allergy shots. But when they get above age 65 and they have, heart disease and they're on a beta blocker and an ACE inhibitor, it makes it difficult for us to treat those patients. So we definitely encourage you, if you are considering allergy injections or treatments or intervention, and to start early. And this is the end. Thank you.